Good afternoon. How are you today?
Good.
Great. So, can I have your name and your date of birth?
Chuck. And
Date of birth?
July 28th.
Okay. Thank you, Chuck. My name is Justine Carol Elgar, a second-year medical student from Southwestern University. So today I'll be taking or will be assessing the musculoskeletal musculoskeletal system. And before we start, please sign this consent form. This is to allow me to record the procedures that we'll be having today and as a requirement of my physical diagnosis class. Okay. Great. So thank you. Do you feel any pain right now? Okay. Now let's start with the temporomandibular joint, and I'll start by palpating your masseter muscle, which is just outside your ear or anterior of your ear, right here, right in front of the tragus. I'll palpate for any swelling or any tenderness. Do you feel any pain or anything? No? Okay, great. Also for the temporalis muscle, which is a fan shape right at the back of the ear for the posterior end, and we also have the anterior end right about here. Okay, there's no tenderness or any swelling at all for the temporalis muscle. Okay, also for the pterygoid muscle, we also have here my two fingers below the mandible, inferior mandible. And for the lateral pterygoid, will just be right anterior to the TMJ. Okay, so there's no swelling or any tenderness at all. Okay, there. Now we will also check for the range of motion for the temporomandibular joint. Now, Chuck, please open your mouth. Open your mouth, okay? I will check for any crepitus, any sound, any click that I might be hearing while he do the range of motion. Close, please. Open. So can you protrude your mouth just half like that? And then retract again. Retract. And then move your jaws side to side. Like this. Like this. Your teeth, your jaw. Okay. Do you feel any pain doing that? Okay, no, great. Okay, so Chuck, we will proceed with the shoulder inspection and also palpation. But my patient is not that comfortable in taking off his shirt. So for the shoulder, I'll check for any deformities, any atrophy, any swelling, or any inflammation. So let's try to palpate. If there's any tenderness, any pain at all? Okay, great, thank you. Also for the back, please turn around. Now for the shoulder blade or the scapula, we'll check the same for any deformities at all. Okay, there's none. Thank you. Okay, great. Now we will do the range of motion. So for the range of motion, let's do the. I will observe for any smooth movement that you'll do. Okay, and if there's any pain at all, please let me know as well while you do the motions. Please raise your arms in front of you and overhead. Okay, great, thank you. That's flexion. For the extension, move it down, move your arms down and extend it right at your back up to where you can reach it. Thank you. That is for the extension. Now for abduction, raise your arms out to the side. Raise your arms out to the side, then overhead. Okay, great, thank you. So that is your abduction. Now cross your arm in front of your body and the other arm, please. Okay, so that is for the adduction. Now for internal rotation, please move down your arms. For internal rotation, please rotate or you move back or rotate back there. And please place one hand behind your back and try to touch your shoulder blade. How about the other arm, please? Okay, so that is the internal rotation. For external, please face in front again. Place your arms down, and then try to raise it up, and try to touch the back of your neck or head just like you are combing. Okay, great. That's it. That's for the external rotation. And now please move your arms down. For the composite test, we will do the external rotation test, resistance test. So for this, I will place my one hand in your elbow and the other hand here on your wrist, and please try to resist this hand of mine while you try to move your wrist outward. Okay, the other. Okay, great. You was able to resist that pressure. If there was any instability of the elbow, then it's a positive test for infraspinatus disorder. Now for the empty can test, bend your elbow 90 degrees, please. Okay, and then move your wrist and your thumbs down. Thumbs down. Okay, just like emptying a can, and then try to resist the pressure as I place downward your arm. Okay, about the other. Okay, so I was able to resist that. But if there's any frailty or any if you was not able to control the resistance, then that is positive for supraspinatus rotator cuff tear. Okay, so for the elbow, let's proceed for the elbow. I will palpate for the olecranon process. Okay, here. And for any also any swelling, any pain at all on the olecranon process on the epicondyles, lateral and medial epicondyles. Is there any pain?
No.
Okay, so there's also no tenderness that I can see here. Now for the range of motion of the elbow, can we do the flexion, like bend like this, bend like this, 150 degrees, this, okay, and then extend, or straighten your elbow. Okay, for supination, please do like this. For the just bend your elbow, okay, and then do like this for supination. Turn your palms up as if carrying a bowl of soup. And for the for the pronation, turn palms down. Okay, great. Thank you. So that is your flexion, extension, supination, and pronation of the elbows, and he was able to actively do the range of motion. Now for the wrist and hands, we will do the palpation first of the wrist joints. Now I will palpate the distal radius and ulna. Okay, radius and ulna on the lateral and medial surface. So I'll palpate the groove of each wrist with my thumbs on the dorsum of the wrist, my fingers beneath it, there. I'll palpate for any swelling, fogginess, and tenderness, okay? There, on the other hand. So I will check for tenderness. If there's any suspicious tenderness on the distal radius, then suspect for Colles fracture. For the anatomic snuff box here, this is a hollow depression just distal to the radial styloid process formed by the abductor extensor of the thumb. So it's more visible with lateral extension of the thumb and away from the hand. How about the other? Is there any pain here? Any swelling or any tenderness at all that you can feel?
No.
Okay, great. So it's here, there. Now for the metacarpal phalanges, we will also palpate the eight carpal bones lying distal to the wrist joint, and then each of the 5 metacarpal joints, and the proximal, also the distal. Do you feel any pain here? Okay, so it's important that we check both, compare it. So the wrist, also the carpal bones, the 5 metacarpals. I know you are working using your keyboards, right? So please let me know if there's any, because at least, you know, if we have any pains here on your joints, hand joints. Okay, so I'm squeezing the hand from each side between the thumb and fingers. Okay, any swelling again, bogginess, and tenderness. Now for the range of motion, please, for flexion, palms down, and put or point your fingers toward the floor for flexion. Now for extension, point fingers towards the ceiling, so that is extension. And now palms down, and bring your fingers toward the midline, just your wrist in there. So that is for adduction or your radial deviation, because the radial is right here, so radial deviation. Then away from the midline, this is abduction or ulnar deviation. Do you feel any pain or any discomfort? Thank you. So if there's any impairment of the range of motion, so it's possible, a possible cause is like arthritis and uveitis. So far, he was able to actively do the range of motion. Now let's test the hand grip. So please grasp my second and third finger. Okay, I'll pull it. Okay, and how about the other side? Okay, so great. He has very strong grip. And decreased grip strength is a positive test for weakness of the finger flexor intrinsic muscles of the hand. Thank you. Now we will check for carpal tunnel syndrome, thumb adduction. So for thumb adduction, raise your thumb straight up as I apply downward resistance. Do you feel any pain here?
No.
So there's also no weakness on thumb abduction. I mean, there is also no weakness that I can see here as I push it down. So that's great. If there's any weakness at all, then it's a positive test. Positive test for thumb abduction. For tinal test, tinal test, this is done by tapping lightly over the course of the median nerve. So please bend your arm again. Palms up. Okay. And then I will lightly tap over the course of the median nerve in the carpal tunnel. Okay. Is there any aching and numbness in the median nerve distribution?
No.
Okay, so if there's any aching on the other side, then that is a positive test for tinal test. Median nerve is right here, this part. Great. Now we can proceed to the Phalan test. For the Phalan test, please hold your wrist in flexion for 60 seconds. Then fully extend by compressing, now for 60 seconds with the elbows, okay? And then now please press the backs of both hands together, form a right angle, there. So this maneuver compresses your median nerve. And do you feel any numbness, any tingling sensation, any pain at all, tenderness, anything?
No.
Okay, great. So if there's no pain, then it's a negative test. But if he feels that numbness and tingling in the median distribution, then that's a positive test for Phalan test. Okay, great. Thank you. Now let's proceed with the spine. For the spine, we will inspect for the cervical, thoracic, and lumbar curves. For my patient, he's not that comfortable in taking off his shirt, so that's why we will just inspect this with his shirt on. So please turn to the side, right, like that. So we will inspect for the cervical, thoracic, and lumbar. So if you notice, we should have here a convex shape on the thoracic part. So we will check out for any kyphosis or any kind of deformation that we have here. Also, please turn to the back. Okay, we will inspect for the upright spinal column, and then inspect for the alignment of the shoulders, the iliac crest, and the skin creases below the buttocks or the gluteal folds. So there's none. I can't see any deformities or any any unequal lengths of the shoulder heights. Okay, great. For also, we can inspect for skin markings, tags, or masses. So far, we'll just assume that there's none. Thank you. So please face front again, chop. Now we will do the range of motion for the spine. So for the flexion, please bend forward and try to touch your toes as far as you are comfortable. Okay, so we'll check for any smoothness, symmetry of movement. Okay, there. And there's a curve. The curve in the lumbar area, as flexion proceeds, it flattens out there. Thank you. There's no deformity too that we observe. No pain at all, right? I'm doing that. Thank you. Okay, now bend as far as possible. And we can do that as well by supporting the patient so that he cannot fully extend to the back. So just support him. That is for the extension. Now, for the rotation, you will also support the patient doing the rotation from side to side. Okay, towards here, please. Rotate. Okay, how about on the other side? Rotate. Rotate. Okay, rotate here, rotate again. Okay, just your here. Okay, great. So why we do that is for him not to fully rotate his body all the way back. So he will also do it against the resistance of my hands on his shoulder and on his hip. Now for the lateral bending, please move side to side. Okay, not fully extend, but just below your hip. Then move lateral bending there on the other side. Bend as far as you can. How about the other? Okay, great. You feel any pain on that movement?
No.
On that. So he was able to actively do those range of motion for the spine. Okay. Okay, so for the hip range of motion, we will do flexion. Normally, hip flexion, it's 120 degrees, and please bend your knee. Bend your knee to your chest and pull it together against your abdomen as far as you can. Then bring it back down. Okay, and same on the other side, please. Normally, the anterior portion of the thigh can almost touch the chest wall. And note whether the opposite thigh remains fully extended, resting on the bed. So he was able to do that. For extension, lie face down. Lie face down, please. Okay, lie face down. And try to lift it up. Lift it up. So the primary muscle here is the gluteus maximus. How about the other one? Lift it up. Okay, great. Was able to do that. Thank you. Now for abduction, this is like 45 degrees with the primary muscle, the gluteus maximus. Please move your leg away from the midline. And the other one, please, the other leg, move it away from the midline. So that is abduction. Thank you. For adduction, lie flat still. Then bend your knee and move your lower leg towards the midline. So like that. No, not totally bend, but just move it to the other, move it towards the midline. Okay, can you do that on your own? Great. On the other side, please. Okay, great. Thank you. So that is the adduction. For the external rotation, so lie flat, bend your knee. This I need to help you on this. Okay. So, and then I'll grasp the ankle by the other and swing the lower leg medially for external rotation of the hip. So like this. Again, on the other side, so I'll grab the ankle and push the lower leg medially for external rotation. Great, thank you. Well, for the internal rotation, still lying flat, and then I'll bend your knee again. Bend your knee. Okay, foot away. So now I will again grasping his ankle with the other, and I'll swing the lower leg laterally for internal rotation. Okay, so this is internal rotation. You feel any pain on that movement? No? Okay, great, thank you. About on the other, still grasping his ankle. Now I will pull it away or laterally. This is external, and internal is swing the lower leg laterally for internal laterally for internal hip rotation. There. So there was no pain at all while doing that maneuver. So our next movement here is for me to palpate your knee. So for the suprapatellar pouch, I'll palpate for any thickening or swelling in the suprapatellar portion. Is ticklish. Is there any pain at all? Okay. And prepatellar. Okay. Swelling here. He's ticklish on his knee part. This answering bursa. Okay, so there's no inflammation, any pain or thickening. Now we are on the knee joint effusion. Let's check for minor effusions using the bulge sign. So I'll press the suprapatellar pouch downward, stroke it downward, just like milking fluid downward. On the medial, I'll place pressure on the medial aspect of the knee. Apply pressure. This is to apply pressure to force fluid into the lateral area. Okay. Tap the knee behind the lateral margin of the patella. Okay. Do it on the other side as well. So see if there's any fluid motion or any effusion at all while I'll do the milking. Okay, there's none. Now for the balloon sign, this is used for major effusion. For the balloon sign, what I'll do is I'll place my thumb and index fingers on each side of the patella with the left hand, and then balloon it into the spaces next to the patella. Okay, so I'll check for any fluid waves. So if there's any balloon sign, go the other side. Okay, there's no palpable returning fluid into the suprapatellar pouch. There's no major effusions. For the ballooning of the patella, it's almost the same thing. Compress the suprapatellar pouch and ballute, or push the patella sharply against the femur. So watch for the fluid returning to the suprapatellar pouch, and I'll place one hand on the suprapatellar pouch. Gently push down the patella, forcing any fluid to accumulate on the central part of the joint. Gently push down on the patella with the thumb. There. So the only difference is that I'm pushing down the patella compared to the balloon sign earlier. We're not really pushing down the patella, but almost the same maneuver. And same thing we will observe for any palpable fluid returning to the pouch, which is positive sign for major effusions. Now let's proceed to the McMurray test. For McMurray test, this is to test the ligamentous stability and integrity of the medial and lateral menisci. So what we'll do here is I'll grasp the heel and flex the knee. Okay, I'll cup my hand over the knee joint with fingers and thumb along the medial joint line. Okay, and from the heel externally rotate the lower leg, then push on the lateral side to apply a valgus stress on the medial side of the joint. So what happens is we will rotate, internal rotation of the foot, and then move. So then external rotate the lower leg. So rotate the foot to the lateral meniscus, and then externally rotate the lower leg, then push on the lateral side Okay, so now let's proceed with the abduction or valgus stress test. This is to test the ligamentous stability of the medial collateral ligament, and still the patient in supine position and the knee slightly flexed. So slightly flexed around 50 degrees and move 30 degrees laterally to the side. And I'll place one hand against the lateral knee and stabilize the femur, and the other hand around the medial angle, and then push medially against the knee. Push medially and pull laterally at the ankle to open the knee joint at the medial side for the valgus stress. So there's no pain at all or gap in doing this. Okay, so let's do the other leg as well. Push medially, and then push medially, and move the thigh. Okay. Okay. There. So there's no pain or gap. And for the adduction or varus test, almost the same position, but this time my hand will be placed against the medial surface of the knee, still the lateral side of the ankle. Now I'll push it laterally against the knee and pull medially at the ankle to open the joint on the lateral side. So again, pulling the lateral side. So that's the varus test. So again, I'll push laterally against the knee and pull medially at the ankle, the lateral side. It's the varus test, and there's no pain again, right, Chop? Okay, thank you. Okay, for the anterior drawer sign, this is to test the ligamentous stability and integrity of the anterior crucial ligament. So Chop, please flex your knee 90 degrees, flat on the foot flat on the bed. Now I'll cup my hands, touching the middle and lateral insertion of the hamstring. Then I'll draw the tibia forward like opening a drawer and observe if it slides forward. Please try to resist from the under the femur slides. If there's any slides, and compare the other one on the side. And try to pull it. There's no forward jerk, showing contours of the upper tibia. If there's any, that's the positive test. While for the posterior drawer, it's again flexing the knee 90 degrees. This is the posterior drawer sign. Then instead of pushing it forward, I'll push it posteriorly. The other side as well. Please flex 90 degrees. Flex 90 degrees. Try to push it also backwards if there's any movement of the bones, frailty, or any clicks like that. So far there is none, so that's not a positive test for our anterior and posterior drawer sign. For the Lachman test, this is another test for the anterior cruciate ligament. So place the knee. We will place the knee 15 degrees in flexion. Okay, we'll do external rotation. So I'll grasp the distal femur. And then on the lateral side with one hand, then the proximal tibia on the medial side of the hand, and with the thumb of the tibial hand on the joint line, and simultaneously pull. Modified version is I'll place my leg here to support and then try to pull. At least I have a force on my hand. Okay. And the same thing on the other side. I'll try to put at least I have a force. Try to pull it. There. So that's the Lachman test. Significant forward excursion is a positive sign for ACL tear. Okay. Lastly, we have the ankle and foot range of motion. For plantar flexion, please point your foot toward the floor. Okay, for dorsiflexion, point your foot toward the ceiling. Okay, now for inversion, bend your heel inward. Bend your heel inward. Okay, for inversion, bend your heel outward. Try to bend it out. Okay, do you feel any discomfort doing that? No? Okay, great. Thank you. Okay, so that's the end of our physical examination, Chop, and we have here a full range of motion in all joints of the upper and lower extremities. Also, there's no evidence of swelling or deformity. So overall, it's we have a normal physical examination. And do you have any questions before we end this assessment?
No.
Okay, thank you so much for your participation and cooperation. Okay, thank you.